We've got to talk a little bit about the normal liver so you'll know how to diverge from the normal liver in disease. And we'll need to know a little bit about form and function, needless to say, so you can understand how liver disease presents in order to be able to distinguish between the various kinds. And then, in general, today we're going to talk about acute disease and its laboratory assessment. Now, I got to warn you, acute versus chronic and liver disease, these are the terms we have, so we got to go with it. But it can be a little bit confusing. I would make the distinction, between acute presentations and acute disease. By acute presentation, I mean if somebody starts off feeling great last week, this week they're jaundiced and they feel lousy, that's an acute illness. It came on suddenly, it's abrupt. Some people would assume that means that it's severe. It's not necessarily the case. And that's an acute presentation. But it turns out hepatitis A is a disease that cannot be chronic. If you don't die from it, you're immune to it. So some people call it an acute liver disease because it can't be chronic. So just be under of the understanding that sometimes you'll see lists of acute and chronic diseases and it can be a little bit confusing. Hepatitis B, as we'll see later, can be a chronic disease, but it can present acutely. And when the patient walks in the door with jaundice and feeling lousy, you don't know if it's going to turn out to be a disease that will be chronic or not, but the presentation is acute. Today we're going to talk about those diseases that are in their acute phase, at least. Tomorrow we'll spend more time with chronic liver disease, which is a very different animal, which is acquired over a long time frame and has really profound systemic consequences. But that's more for tomorrow. And then we'll have a few cases to try and make this more vivid. And then Dr. Hansen has got a great presentation on liver histology and pathology, which is still huge in liver disease. It's one of the few places really left in the body where the microscope is pretty crucial. And then, I can't see my own slide, and then tomorrow, chronic liver disease and cirrhosis. So, let's talk a little bit about the function of the liver in order that we can think a little bit about its malfunction and how that presents as liver disease. The functions of the liver disease include functions of a normal liver, just broadly speaking. I'm trying to focus on those things which will be most important to understanding liver disease. One general function is the liver's synthetic function, and by synthesis in particular, with respect to liver disease, we'll talk about albumin and clotting factors. Albumin is, as you know, the most abundant protein in the body, the chief source of oncotic pressure in the circulation, and is exclusively made in the hepatocytes, the major cell type in the liver. But the liver also makes clotting factors, and those are important functions, all of which, when thwarted, have manifestations in disease. The liver is also a source or a site of transformation. You're going to have a lot of information on metabolism coming up, but when you think about what the liver does, among many other things, there is this metabolism of what we call xenobiotics, with exogenous and potentially toxic chemicals from the environment, and particularly those that are from bacterial in origin, which I'm going to just use endotoxin as the shorthand, the lipopolysaccharide aspect of the gram-negative rod. These are compounds which ordinarily circulate in the body, but we aren't aware of it because the liver is filtered and then transformed and therefore rid us of these problems. Needless to say, if the liver isn't working very well, we can have problems with all of those things. And we'll definitely hear more about that. Tomorrow we'll have a patient in here who will talk to you a little bit about what it's like to have circulating toxins in the blood because of this chronic liver disease. And then the liver is also a site of processing of a number of different compounds for excretion. The body has a problem to get rid of both water-soluble and fat-soluble waste, right? The kidneys are great with water-soluble, but the bile is the site at which fat-soluble materials leave, also some water-soluble. In other words, it is a place by which we rid ourselves of some kinds of compounds we couldn't otherwise, and the processing happens to include the constituents of bile salts, cholesterol, phospholipids, but also a very useful compound, bilirubin. It's very useful because it has a color, and if you're not processing it, you have that color. And so it's like having a built-in colorimetric index in the human body. It's about the only, well, I guess anemia, when you get pale, is similar, but it's a place where there's a visual analog to disease. So needless to say, if you're not processing bilirubin normally, you look jaundiced. And so it is another aspect of normal liver function, which, when thwarted, leads to disturbed health. And And so in general, broad terms, if there's a problem with the synthesis of albumin, it contributes to the edema-forming state, the ascites-forming state, the accumulation of fluid in the belly. We'll talk about more tomorrow. If you lose clotting factors, then bleeding is a problem, right? And there are laboratory analogs for all of these things to have metrics and sort them out further. If you have trouble processing or filtering and clearing the body of what we call generally toxins, it's a broad term, but for our purposes that's fine, then the confusional state, the psychomotor retardation and even coma of hepatic encephalopathy can follow. If you're having trouble processing bilirubin, you're jaundiced. So all of these things reflect fundamental functional disturbance of the liver. It's not the only set of things the liver does, of course, but for our purposes, they're the ones that we'll focus on because they'll be the sources of some of the signs and symptoms of liver disease. So let's look at the neighborhood of the liver first, just in a general way. You can see there's a big right lobe. This is the liver is looking at you from the table, so here's the right lobe, a smaller left lobe. There's what's called a caudate lobe. We can't see it, sort of on the other side, but you can see the blood egresses from the liver by the usual blue venous structure. It's by convention blue in all these diagrams. The hepatic veins. You can see a little red input that's coming sort of under the duodenum here into the liver. That's a hepatic artery. But you also see another blue structure bringing blood upward into the liver, and that's the portal vein. So the liver is unique in having two sources of input blood supply, both arterial and venous. The portal system, which we're going to talk a lot about tomorrow, is the source of the portal venous input, and that is input that comes from the viscera primarily in the abdomen. And you can see these are structures that are not easily accessible. They're sort of wrapped underneath the duodenum. They're above the pancreas. You don't see very well here the biliary system. You see the gallbladder is sort of a shadow here. That's because it's typically tucked up under that lobe. So when I have patients that tell me they went to their chiropractor for a gallbladder massage, I'm always intrigued by how he got his hand under there. But you have to pay. Insurance does not cover your gallbladder massage, as it turns out. Anyway, so those are the structures of the neighborhood of the liver, and it's worth reflecting on that just in terms of where things lie and how you would get to them. We'll show you a couple more pictures to make that more clear. Here's a diagram just showing you where the liver is with respect to the rib cage, just to remind us. And most of it is up under the ribs. In fact, it's only in about a third of patients that you'll feel the liver edge. And when you do, you'll be most likely to feel it over by the midline. There's the xiphoid, right? So we're just on the left of the midline. That's probably the most likely place to feel it. The most likely place you might feel an abnormal liver if the liver is scarred and hard and because of cirrhosis, for instance. But most of it is up underneath the dome of the diaphragm, so it's not really accessible to our physical exam. And therefore, when we measure it, we're percussing the top to get a feeling where the top is by dullness and trying to feel for the bottom. And it can be quite accurate, but it's always involves a little bit of maneuvering. If we look at the sort of subtract out everything but the biliary system so we can see that a little bit better, here you see the important relationships. The bile is leaving the liver, and the gallbladder, of course, is just a side pocket. It's a little reservoir. And the bile duct itself travels down through the pancreas to get to the duodenum. That's worth remembering or thinking about. That means if somebody's not processing bilirubin and they're jaundiced, it could be a problem in the liver, but it could be a problem in the exit from the liver through this structure. And that could even mean a problem in the pancreas. If that's where if there's a tumor growing in the pancreas that crowds the common bile duct, then a pancreatic cancer could present with jaundice. Worth knowing, just because jaundice is not always reflecting intrinsic liver disease, it can also reflect a problem with the exit of bile from the liver. The liver has a segmental anatomy, and it's not. I don't think you need to know this in any detail, but I think you need to at least think about it a little bit. It just reflects the fact that the blood supply to the liver branches, and the branches supply the segmental anatomy, which you sort of see best on cross-sectional imaging, like a CAT scan or an MRI. It's terribly important if you're doing surgery, because if you have a lesion that bridges the left and the right side, you have two different circulations. You have a surgical problem, it's quite different than if you have a lesion that's out in a segment that's isolated and could potentially be resected. So segmental anatomy is pretty important to the treatment of liver cancer in particular and liver surgery in general. So you need to be aware of it. But by and large, you don't see it, right? The liver just looks like a homogeneous organ. This is internal. And so if you pursue liver disease, you'll learn more about it. But for the moment, the important thing is just to know it exists and there is segmental anatomy. The patient says, can I have a surgery and cure this? You can't really say until you know where it lies in the segmental anatomy. But let me show you one more picture here, and this may be the most important one. We've subtracted out now the hepatic artery. We aren't seeing that input. We're really just seeing the input from the portal system that I mentioned earlier, and the origin of the portal blood flow from the spleen, and then from the superior and inferior mesenteric arteries, serving the small intestine and stomach and pancreas and through the superior, and the distal colon from the inferior, and all of them converge and make the portal vein passing blood into the liver. It's the chief source of blood flow to the liver. It's higher volume than the arterial blood flow. And since it's coming from the bowel, you know it's containing everything that you just absorbed from your last meal, right? All the nutrients broken down and digested intraluminally and are brought into the bloodstream from the portal system travel directly to the liver. That's their first stop for further metabolism, distribution, and so on. And if you sort of reflect on this a little bit, that means if you had trouble in the liver and put back pressure on this portal system, you could have impact that would be potentially immediate on the spleen and on the bowel. So we'll talk more about blood flow tomorrow because chronic liver disease tends to disturb this portal system. But it's an important diagram to which we'll return in various forms now for the next couple of days. And kind of getting a grip on the fact that there is this whole portal system is a big part of getting a grip on liver disease, which I might add I never did as a medical student. I flunked my liver histology class, and it wasn't until much later that it kind of made sense to me. But this is a diagram I wish I had understood when I was in your place in the classroom. To understand one last picture to help drive home the sort of importance of the various circulations in the liver, a liver surgeon doing a transplant has to do 5 different anastomoses. Okay? There are 5 different tubular structures, conduits that have to be severed and then reattached. Because the vena cava from the lower extremities travels right through the liver and becomes the superior vena cava above the liver, so you've got to detach it below and above. That hepatic artery has to be detached, the bile duct has to be detached, and the portal vein has to be detached. So the liver has these 5 different conduits that reflect input, output, and then bile itself as another form of output. And so it's it's a unique organ by virtue of this dual blood supply and the biliary egress. And those are some of the structural constraints that are conferred upon it by that anatomy. So if we follow the anatomy down to the microscopic level, and we're going to get a lot more about that here later this morning, this diagram is going to be hard for you all to see, but the point of it is that in the middle, there's a vein. They're down embedded in the structure of the liver. And that vein is the egress vein, the hepatic vein that we looked at the very top of the liver, carrying blood back into the vena cava. At the level of the liver itself, that's the egress. The blood flow into the liver is coming through little bundles that are sort of scattered around the outskirts here. I'm not sure I'm putting my pointer right on it. But the hepatic artery, the portal vein, and the bile ducts are in little bundles, sort of circled around, and the blood flow comes in from those structures, and then passes between the liver cells and goes out from the central vein. So the functional unit of the liver, which we're going to go into in more detail, this is hard to get a grip on from this picture, but the functional unit still reflects those macroscopic structures. Input from the portal vein and hepatic artery, pass through the liver cells, output through the hepatic veins themselves. If you look at that, it's maybe even a little better to see, easier to see on a H&E stain here, hematoxin stain. You have the central vein vein right here, if I'm seeing it right, and then you have these little structures on the side. This is going to be a bile duct and a hepatic artery and a portal vein, and they're scattered around. They'd be over here, here, and here, and the blood flows between all these little red liver cells to the hepatic vein and out. So the structural unit of the liver is like a small miniaturized version of the liver itself. Two input blood supplies, one output blood supply, liver cells in between. Those liver cells are mostly hepatocytes. Hepatocytes are the chief cell of the liver, the major cell that produces most of the clotting factors, all of the albumin, does the xenobiotic transformation, processes the bilirubin, and so on. But it's not an organ made of a single cell population. There are endothelial cells because there are these passages through the liver itself. There are so-called Kupffer cells. It's one of the acronyms that you have to just know. This is the dedicated set of macrophages that live in the liver. I mean, there are, after all, white blood cells that pass through the liver all the time. It's a very vascular structure. But there is a set of resident macrophages that live there. And if you think about that a little bit, then think about its filtration function. No wonder you've got to have the troops on the ground to ingest and deal with bacterial products and so on. The bile ducts have their own cell type, and then there's another cell type we'll talk more about tomorrow that's rather important, a fat-storing cell. Dr. Ito first described it. It's got a star-like appearance, so some people call it a stellate cell. With further study after its first identification has been demonstrated, it kind of acts as a myofibroblast, so it has a number of different names. But these are the major cell types of the liver, and the supporting cast, these four, are what allow the hepatocytes to assume a normal phenotype and do their normal thing. The hepatocyte itself, as I said, is a site of these various functional structures we were talking about before, and the hepatocytes are lined up like little plates with the blood flowing by them. We sort of got a glimpse of that thinking about it on the last slide, from the portal vein through the plates to the hepatic vein and out. And then between the cells, the liver cells themselves, are the passageways, the little tiny canaliculi, as they're called, into which bile products are being excreted, and which become larger and larger, like a stream into a rivulet, into a river, and so on, and finally become the bile duct itself. So the hepatocyte is the major machinery of the liver's function, but we'll see, especially tomorrow, that without the support, it can't function very normally, and good things don't happen if that's the case. It is also the hepatocyte which, when injured, leaks out the things that we mostly measure to determine the degree of liver dysfunction or liver injury. And so when we talk about the metrics, liver function tests, as you've seen them already, I'm sure, we're really talking mostly about things that originate in the hepatocyte itself. So some years ago when my kids were little, I was doing a presentation on acute liver failure, and I asked my kids, how do you hurt a cell? I mean, what are the mechanisms by which you could hurt a cell? And they were pretty straightforward. You could strangle it, you could poison it, you could bonk it, you could betray it. I was surprised about that. You could infect it. And they didn't talk about making it fat and lazy. I was much younger then, and this had not occurred to them. But there are analogs for all of these things. This is really exactly the kind of set of problems that results in liver disease. If there's ischemia, you can essentially strangle hepatocytes. If there are toxins, whether that's iron or copper, more commonly alcohol, you can certainly poison hepatocytes. If there's traumatic hepatitis, a steering wheel injury or a blow can do that. Autoimmune hepatitis, where the body's immune system is targeting the liver inappropriately, is kind of a major betrayal. And there's infectious hepatitis, as well as fatty liver, which we call non-alcoholic steatohepatitis. Steatohepatitis means fatty hepatitis, and hepatitis means inflammation of the liver. It's called non-alcoholic because it looks exactly like alcoholic hepatitis under the microscope, except there's no alcohol. So these are all this is a reasonable way to think about the kinds of things that injure the liver in terms of their categorization, and we'll talk a little bit about how we would measure the consequences of these and fill in some of the diseases that work by these mechanisms. I'm going to just skip that in the interest of time here. Let's talk about hepatic function panel then for a moment. It may seem like we're getting a little ahead of ourselves. How do you measure injury? We haven't really talked about the diseases yet. But all of them have, no matter what liver disease you have, you're going to assess that liver disease by certain very meaningful, very useful kinds of techniques. And the laboratory blood testing is really primo here. And as students, you'll spend some time learning about liver tests, and probably on the wards you'll be bringing them to the residents and reporting on the liver tests, so we ought to talk a little bit about what they are. The major liver tests in a panel, this is a defined panel. It's a Medicare-sanctioned $39 per panel lab test, and so it's standard everywhere, and the techniques are standard everywhere. It's the same here as it would be in Michigan or Madagascar. The bilirubin is one of these measurements. It's called total bilirubin, typically, on this panel, because it hasn't been subdivided into whether or not the liver has begun the process of bilirubin metabolism into direct versus indirect, and we'll talk about that later. There are the aminotransferases, alanine and aspartate aminotransferase, which are usually abbreviated ALT and AST respectively. In older literature, you'll see older designations. You probably don't need to think about those too hard these days. That nomenclature is about gone. There's alkaline phosphatase, albumin, and then there's total protein, which is not maybe really a liver test per se, since it includes immunoglobulins and various other circulating proteins, but it gives you a denominator when you're talking about albumin. So if you're talking about the total protein environment in the body, it's useful to know the total in comparison to albumin. So these are the major, in fact, the only tests that are on this panel. There are other liver tests, we'll touch on some, but these are the ones on the hepatic function panel. And so let's talk about how you use them a little bit. I think it's meaningful to group them in terms of what they tell you. The bilirubin test is telling you about this pigment that I've mentioned, the yellow-colored pigment or greenish-colored pigment that is the major color in excreted bile. It's not the major constituent, but the major color. And if there's a problem with the plumbing of the liver that's pretty serious, then that bilirubin will not be exiting through the bile, and it'll be higher in the bloodstream. And so whenever bilirubin is elevated, you have a plumbing problem. That plumbing problem could be, as we saw before, at the level of the pancreas and the bile duct, or in the bile duct. Could be in the hepatocyte, with the problem excreting bile into the canaliculi. Could even be a problem getting the bilirubin precursors into the biliary excretion system. But there's a problem somewhere along that line, and so that means it's pretty easy to say, gee, the patient's jaundiced. We have a problem in the biliary tree. That's a very, very specific sign. Transaminases, the AST and ALT, these are of liver origin. They are working within the hepatocyte. If the hepatocyte's injured, they are leaked, and so you see them in higher abundance in the blood. Exactly what they're doing in the liver really isn't pertinent to liver disease. It's pertinent to metabolism, but not so much to liver disease. But if the transaminases are elevated, then you have injured hepatocytes, right? They're hepatocyte specific. It doesn't mean the bile duct's injured. It doesn't mean the endothelial cell's injured. It means hepatocytes are injured, and they're leaking these compounds. Now, transaminases are also found in muscle, as it turns out, less abundant, so you may have to do a little bit of thinking about whether they are from the liver. But if they're from the liver, they're hepatocyte in origin, and there's injury, and that's a snapshot. You don't know how long there's been injury. You don't know how consequential it's been. You don't know if it's had impact on liver function. All you know is there's injury. It's a snapshot. It does not tell you anything about prognosis. Alkaline phosphatase, again, its actual work as a phosphatase isn't so relevant to us. It is elevated in the setting where the liver is under pressure. And so if you think about anything that puts pressure on the liver, that could be a blockage of bile flow. So there's biliary pressure. It could be an outflow problem from the bloodstream. It could be there's fat in the liver that's stretching it within its capsule. It could be there's a tumor in the liver that's crowding the structures. Anything that causes pressure in the liver will raise the alkaline phosphatase. Again, it could be from bone. You might have to think about that a little bit, but if it's from the liver, it does mean pressure. Now, these are not mutually exclusive. If a person has enough injury to the liver, enough injury and enough inflammation to raise transaminases, these swelling may also raise the alkaline phosphatase. But a problem that's mostly injury will have a dominating elevation of these enzymes. A problem that's mostly pressure will have a dominating presentation of these enzymes. So it is meaningful, not that they are all one or all the other, but which one predominates. The albumin is more like the view from 30,000 feet. Albumin has a very long half-life, 3 weeks at least. So if you shut off your albumin synthesis today, it will not be measurably lower tomorrow. But if it's low and consistently low because of the liver, then there's a problem with your parenchymal mass and its function. And so it's not something you would ever measure in a day-to-day way, but it gives you kind of a big picture view of whether the liver is functionally intact or not. It is greatly influenced, that is, its induction or its transcription is greatly influenced by inflammation. So in the setting of inflammation, when you have, I don't know if you run into all the cytokines and TNF-alpha and all that good stuff. Yeah, in those settings, TNF-alpha, for instance, has a cis-acting element on the albumin promoter, so you can down-regulate albumin in the setting of inflammation. And there are at least 50 or 60 different cis-acting elements there that are all reducing the transcription of albumin in the setting of inflammatory events. So you expect it to be low in somebody who has rheumatoid arthritis, for instance. That's not a liver problem, but there's enough inflammation that their albumin may be low. So all of these things always require you to think a little bit about context. But those are the ways to think about what these mean when they're elevated. So let's talk a little bit further about each of them, because you just have to know this to be able to talk about liver injury and therefore about liver diseases. Bilirubin, as I say, is a breakdown product of heme, the molecule that's at the center of hemoglobin and in cytochromes and several other places in the body. Red blood cells are breaking down every day, right? They have a half-life, they have a lifespan of maybe 120 days or so. So you're constantly recycling heme. And that particular molecule has to be rendered water-soluble to excrete, and so it is conjugated in the liver. The enzyme glucuronidyltransferase is the enzyme that does this. Once they're conjugated, they can be excreted in the bile. Once it's conjugated, we call it direct bilirubin. It's archaic nomenclature, but it's no longer total bilirubin. It's now direct-acting or conjugated bilirubin. If it hasn't been conjugated, then it's indirect bilirubin, okay, unconjugated bilirubin. Now, if you think about that for a second, that means if you have a problem with the glucuronidyltransferase or a bigger problem in the hepatocyte such that it's not able to do the conjugation, then you will have a lot of indirect bilirubin around. Right? But if the liver is working at least well enough to do the initial step in excretion, the conjugation, then you'll have a lot of direct bilirubin around, conjugated bilirubin. Does that make sense? The first step, I'll show you a picture here in a second. Bilirubin is in circulation, has a relatively short half-life, but if you have high levels of bilirubin so that the bloodstream is full of it, it starts to displace other molecules from albumin, links to albumin, and that really extends its half-life. You don't excrete it very well. So if somebody's had a bilirubin level that's 20 times normal for a week or two, it'll take a long time for that to resolve because that bilirubin is no longer going to be excreted normally. If they have a big problem with the excretion of bilirubin, you can't expect the bilirubin in the bloodstream to come down quickly, even when that problem is resolved. You unplug the bile duct, it's not going to go away straight away. Let me show you a picture to make that a little bit more clear. Yeah, I was going to, as mentioned earlier, it's kind of like having a built-in colorimetric test. If your eyeballs look yellow, and then you know there's bilirubin where it shouldn't ought to be, you know there's a problem in the liver or biliary tree, and so it's a kind of a free test to look at somebody's sclera and see that they're yellow. You probably have to have a serum bilirubin of about 3 before we can reliably detect yellowness in the eyeballs. But to put this into more of a schematic kind of picture, red blood cells break down, right? We have the heme molecule. It breaks down to bilirubin, but has to get into the liver and be conjugated to be excreted as direct or conjugated bilirubin into the bowel. Comes down through that bile duct, passes through the pancreas, doesn't interact with the pancreas, it's just passing through into the intestine, and it's further metabolized by bacteria down here. It's one of the chief pigments in stool, for that matter. If somebody has no bile passing into the stool, their stool looks almost silver, almost gray, almost like putty, or something like that. Occasionally somebody with total biliary obstruction will notice that before they notice anything else. The bacteria in the bowel can metabolize the product here, bilirubin, and they make a product that then is reabsorbed, urobilinogen, that can come out into the urine. I don't think we have to worry about that so much today. But the main issue is that if the breakdown product of red blood cells is in abundance, it exceeds the liver's capacity to metabolize, then you'll have a lot of indirect bilirubin in the blood. If the liver has a problem with metabolizing the direct bilirubin or has trouble passing into the biliary system, you may back up and have a lot of conjugated bilirubin in the blood. So if you put a stone in the middle of the bile duct, you'd expect the backed up bile spilling out of the liver to give you conjugated bilirubin or direct bilirubin. And that's the way we use those laboratory tests to begin to think about where the problem might be, the problem that we recognize first, just as jaundice, just as yellow complexion. There are other aspects of bile. I don't want to make it sound like bile is all about bilirubin, but bilirubin is the pigment, just convenient for us to help track bile and where it's flowing. To give you a visual analog, this is an X-ray of a patient who's having an ERC, an endoscopic retrograde cholangiopancreatogram. That's such a mouthful, we call it an ERCP. The scope is passed down the esophagus into the stomach. You kind of get this black view here, that's gas in the stomach. We're passed through the stomach into the duodenum. There's a little catheter out here that squirted some bile back into the common bile duct. It's traveling all the way back up, and in the liver it begins to branch out into those small branches, which bile's going the other way, really, or from which the bile's gathering into the common bile duct. So you can imagine problems anywhere along this structure, all the way up into the liver where these small radicals are, could cause bile to back up and flow into the blood. In fact, in this particular picture, you can kind of get a sense that this column of dye is interrupted by these lucencies. Those are all stones in this case, and this is a procedure to pull those stones out of the bile duct. But that patient presented with jaundice. It was direct bilirubin. It had already gone through the liver. It just couldn't get out of the bile duct. Okay? Does that make sense? Okay. Let's talk for a moment about transaminases. We'll just talk about one because they basically are, for practical purposes, the same as what they do. I mentioned before it's found in other organs besides the liver. Kidney hardly ever comes up. Muscle occasionally. In most liver diseases, where the liver's injured, where hepatocytes are hurt, whether there's bilirubin or not, the ALT is elevated, probably a little more than the AST in most cases. And it's the first thing you see when there's hepatocyte injury. So a patient may have what will turn out to be a disease-causing jaundice, but the first thing you may see if they happen to have blood drawn is the injury to the hepatocytes. The upper limits of normal, or ULN, on this particular lab test, vary with weight and with age, and probably with several other factors. So when you look at lab tests and you see a little star next to one, and you say, that's abnormal, probably in all cases we have to remember these are probabilities, but particularly for this test, if you're a small Asian woman with a normal ALT, it might be elevated. If you're a large black man with a slightly elevated AST, it might be normal, because body mass, racial origin, both have an influence. We don't have to get into the nuances of that today. The take-home point is take the upper limits of normal with a grain of salt. For these tests, the patient's better off having their value in the lower end of the reference range. You can't say just because you went from 65 to 64 now you're home free. You'd rather have be in the low end of the reference range to indicate a normally functioning liver that is without liver injury. If you're treating somebody, for instance, say a fatty liver, you like them to lose weight and have those numbers go down. You don't stop just because you've gotten above the star, from abnormal to normal. You'd like to have them in the lower end of the reference range. So that's an important thing to remember with respect to these particular tests. Their half-life is a matter of a couple of days. So again, if somebody has acute injury, you can't expect the liver test to return to normal overnight. It takes a little while to clear these when they're spilled into the bloodstream. Broadly speaking, ALT, AST, the transaminases, have kind of ranges that are pretty broad of how abnormal they are for various categories of disease. So here's the measurement on the side in the international units that we use, and here's the normal upper limit, as we call it, the reference range, which, as I say, is a fuzzy line, really. So normal folks are all up and down through here. We might say, really, it's better to be down here to be totally normal. But patients with cirrhosis could have normal liver tests for AST and ALT. Patients with chronic hepatitis of diverse origins could be normal, but they could also be high. But some diseases are characterized
characterized by simply a higher, broader range. There's so much overlap. You can see you can never use these tests to pinpoint a diagnosis. But if you're very high, you might say, gee, it's a lot more likely that this is ischemic, that you're strangling the liver acutely, than that you have chronic cirrhosis, or that you have acute hepatitis rather than something that's been there for a long time. These things tend to be more low grade. So you can see that categorically these sort a little bit, but not enough to hang your hat on, not enough to make a diagnosis about. If you're on the high end, it skews your differential diagnosis to a set of things you might not think about on the low end, but they're none of them going to be what the lawyers would call dispositive, giving you a disposition. Furthermore, in the course of looking at liver tests, they change over time, right? So here are two, this is a little bit tricky, but there are two different processes here, and they're all superimposed. There's a ischemic hepatitis, and that's in green and yellow. And then in a moment we'll look at viral hepatitis. So the green, in this case, is the AST, and the yellow that you see under it is the bilirubin. And you see ischemic hepatitis, there was dramatic injury, very high transaminases. But it also came down very quickly. Blood flow was restored, the injury repaired very quickly. And so if you look at a lab value here, and you think you understand what's going on, and you get a whole different picture than if you looked at it, 3 hours later up here, or 12 hours later over here. And so following the contour of liver tests always gives you some insight into what's going on. And that insight includes the fact that the transaminases are the early warning and the dramatic indicators of injury. The bilirubin effect, in this case there was enough edema to change bilirubin count, slower and slower to resolve. Here's a patient with viral hepatitis. Maybe they just got hepatitis B. So their increase in injury was slower and broader and took longer, and their bilirubin was much longer to resolve. And so it's a different contour. But you could imagine a blood test here, it tells you, if you just had one number, you wouldn't really know where you stood. But as soon as you have this number, this number, and this number, you can say, it's slow and it's getting better. Or it's very high and it tells me about a particular set of possibilities. So liver tests, we talk about them in isolation, but interpretation, they're always in time, in real time. And so they're a test you'll always want to, you almost never order it once, unless it's normal. If it's abnormal, you're going to want to order it again, because you don't really know where things are until you begin to get a contour in time. And that'll also be more clear as we look at some of these particular diseases. If you talk about, we're still talking about AST here, or ALT, the two transaminases, you talk about the kinds of diseases in which they're elevated, well, they're the kinds of diseases where hepatocytes are injured. Alcohol is a big one. Oddly, the AST tends to be higher than the ALT in alcohol. Non-alcoholic fatty liver disease, if the AST is higher, it's usually more severe. But toxic, ischemic, viral, autoimmune, metabolic poisonings with iron or copper, all these things injure hepatocytes. All these things are the things that tend to elevate transaminases, and therefore, from the other way around, you see the lab with elevated transaminases. These are the things that you think about first, granted the caveat of looking at the time course for these tests. So we talked a little bit about bilirubin, we talked a little bit about transaminases. Let's go back to alkaline phosphatase for a second, another test on this panel. As I say, it can also be from bone, and so it can also be from placenta. The third trimester female has a pretty high alkaline phosphatase. An adolescent in growth phase where bones are growing has pretty high alkaline phosphatase. But if the context's right and it's liver disease, then it's telling you about pressure. There are other isoforms. There's an intestinal fraction. It hardly ever comes up, honestly. It's just there's not enough of it to interfere with your measurements. But every now and then you see somebody where you've got slightly elevated alkaline phosphatase. You're not sure. Could it be from the intestine? You make them fast and repeat it. And if it's back to normal, you say, we had some intestinal tucked into that lab test and we can disregard it. But those are the kind of the caveats to think about with alkaline phosphatase. How do you know if it's from bone or liver? Probably the easiest way is just to do another test that's a little more specific for the liver. So, for instance, here I guess I put it on the next slide. In general, the elevation is is not because it's leaked from the liver cells. It's actually induced in synthesis in the setting of pressure. And it's a little pearl. It's typically low in Wilson's disease. That is very esoteric, but it turns out it can be kind of important. We'll come back to that later too. But how do you determine if it's from the liver or not? It used to be that you could fractionate for isoforms because some bone has a different heat tolerance than liver. The enzyme, you heat the assay and repeat the assay, that kind of thing. But these days, most everybody would simply do another blood test that should be from the liver. Okay, and GGT, or gamma glutamyl transferase, is the most commonly used one. If the alk phos is up and GGT is up, that's probably from the liver, because GGT wouldn't be up in the bone. So you usually do that as a sort of a corroboration kind of a test to be sure you've got the right context. And then albumin, I mentioned, is hepatocyte specific, greatly influenced by inflammation. But you've got to have a pretty sick liver, chronically ill liver that has lost a lot of parenchymal mass and a lot of capacity before you'll have low albumin purely from synthetic dysfunction. But you'll have it, because you'll see patients with cirrhosis, and it's quite typical in cirrhosis, where the liver is shrunken and the cells are not working very well and the mass is low, to have low albumin. So we'll end up necessarily talking more about that also tomorrow. It's an important liver test, but it's more of a view from 30,000 feet. There's one other test we really should call a liver test. In some ways, it's probably the most important of all. It isn't on that panel. It's a test of blood clotting. Prothrombin time, which has been changed to the nomenclature of the INR these days, International Normalized Ratio. It's just to do with the assay and how it's done to be sure the labs are doing it the same way. But this is truly a function test. You can argue that transaminases are not a liver function. I mean, they're leaked when you're injured, but they aren't really a functional test. But clotting tests are functional. If the liver is working, you clot properly. If the liver is not working, you don't clot properly. It turns out that all the clotting factors are made in the liver, mostly, though not exclusively, by hepatocytes. There has to be some vitamin K-dependent carboxylation after these clotting factors are manufactured. So you can screw up your clotting for reasons other than liver disease. But if it's liver disease that's the problem, and the clotting is off, you have a very serious problem, because you have to lose a lot of function before you do not have sufficiency of clotting factors. And so if you see a patient who has liver disease and their INR is elevated, or worse yet, you've been tracking, as you always will, liver tests over time, and the INR is rising, that is an emergency. That is a serious problem. The liver may recover. It's not that every time it's up, it's a disaster. But if it's going up, the sun should not set until you understand what you're dealing with, because a rising INR just means you've had massive destruction of liver function. And so it's a very, very useful test. If you think about these things sequentially, the transaminases maybe told you there was an injury. Maybe the bilirubin is rising, tells you the injury is fairly significant, affecting the plumbing. Now you see the INR is rising, saying we have a really serious problem here. Yes?
Can you still use the INR as a function of liver function if they're on anticoagulants?
Not if you're on an anticoagulant that bumps the INR. Coumadin, for instance, the most common. Yeah, then you're robbed of that ability. You might see the INR moving and wonder, is it the liver or is it some erratic absorption or something drug-related? But it really blinds you, unfortunately. Yeah. And the other implication of that is a good point, because it's reminding us that other things can affect the INR besides pure liver function. If you want INR to be a window on the liver and only the liver, you got to give some vitamin K to be sure you're not getting thwarted by the lack of that nutrient. After all, we're talking about a setting where the bile might not be normal, and biliary excretion might not be normal. Bile is a number of different things that it does. It's ridding us of waste, as we said earlier, but it also becomes essential to solubilizing fat-soluble material you absorb. Vitamin K is a fat-soluble vitamin. So if you're very jaundiced and not putting out much bile, you might not absorb vitamin K very well. And your INR might start to rise, not because of the liver disease, but because of the lack of vitamin K. So I tell the fellows in training, whenever you have an elevated INR and you are worried that it's in context it's telling you about the liver, the first thing you should do is give vitamin K.
give it a sub-Q or IV or some way that you don't have to absorb it through the bowel, and give yourself a chance to repeat it and see if it really is still elevated in spite of the availability of that nutrient. So it's a little caveat. The INR has always got that little asterisk. Check to be sure vitamin K is sufficient before you use it as a sign of liver disease. But if it is a sign of liver disease, it's a very serious sign of liver disease. So, how do we diagnose relatively uncomplicated liver disease? Liver disease, we'll say, is newly discovered or acute in origin. There are symptoms, but the symptoms are pretty nonspecific. A person who has acute hepatitis A may feel malaise, may feel nausea, may feel a little appetite, kind of a viral syndrome you sometimes sort of lump it as. No different from hepatitis B, no different from hepatitis C, maybe no difference from a drug-induced liver problem. The symptoms themselves that the patient feels, that the patient experiences with acute presentation, they just aren't very specific. You couldn't listen to a history and know what you were dealing with. You might say among the possibilities is liver disease, but it wouldn't be enough by itself. The signs of liver disease are much more helpful. That's how jaundice is so useful. Somebody comes in with malaise and they also have yellow eyes. Now you already know what you're dealing with. It's presented to you with some specificity. There are some signs in the body. Somebody says, I have abdominal pain. All right, there's a starting point, but it could be 100 things. But if somebody has jaundice, there's a problem in the biliary system, so it's quite specific. When you're talking about liver disease, there are risk factors for many liver diseases. If somebody's drinking alcohol, that's a risk factor. It could be relevant. If somebody's has injection drug use, that's a risk factor for viral hepatitis. If somebody's taking multiple medications and supplements, there may be medication-related issues that could cause liver problems. So the risk factors may help you to home in on the general idea. And you always ask about medications and ingestions. There are familial liver diseases. They don't usually present acutely, that is, they don't present abruptly, but they might. And so whether there's family history of liver disease is always relevant. If you ask the patient, do you have a family history of liver disease, and they say, yeah, my grandfather died of cirrhosis, that might be helpful. You always have to ask the follow-up, do you know why? Because if you ask that, they may say he drank a lot, or they might say nobody ever drank in my family, and they never could explain the cirrhosis. Those are two different family histories that make an important distinction, but the family history may be relevant. And the physical exam is also potentially quite relevant, and we're going to talk about that further here, probably especially tomorrow. But if you have enough to go on to say, I think we have liver disease, then especially if you have an elevated bilirubin, which is part of how you got here, you're going to want to assess that biliary tree, and the easiest, safest, cleanest way to do that is going to be by an ultrasound. No radiation, no preparation really. And you're going to want to do the liver test we just talked about and see, do we have a predominantly hepatocyte injury pattern? Do we have a pressure pattern? Do we have bilirubin that's conjugated and direct, and we know the liver cells were at least able to do that, and therefore the problem is somewhere post-conjugation or not? Those are the things you'll learn from the laboratory test. Now, non-alcoholic fatty liver disease is on the other end of the spectrum. It's probably the most common liver disease in the country. It will very soon be the most common reason for liver transplantation. Now that we're curing hepatitis C, the projections are that it'll be the most common by the end of this decade. So here we have the extremes. We have a rare disease, but when you have to be aware of because it is potentially lethal. Here we have a common disease that's easily overlooked. It's not very dramatic, and so it's easy to kind of say, you should lose some weight. But it's, in aggregate, responsible for a huge burden of liver disease in this country and around the world, actually. When it presents usually not with any acute illness. People don't have elevated bilirubin and come in because they feel lousy. It's usually found in lab screening. Their bilirubin may or may not be elevated, but they might have a little bit of transaminase elevation. That may be all there is. It gives away that there's a problem. Or they might have an imaging test for some other reason and show probably some fat in the liver. These are patients that often have hypertension and diabetes, lipid disorders, the so-called metabolic syndrome. Their transaminases may be quite normal or just slightly elevated. I would say, the range is maybe 1 to 4 times normal. It's usually 1.5 times normal, something like that. They may have some things that distract you. They may have a little bit of autoimmune marker. They may have a little bit of
iron level elevation that might make you think about other conditions for a while. And at the time they're recognized, almost probably 15% are already cirrhotic, silently become cirrhotic and had no idea that they had this disease at all. And in a larger cohort, or at least having advanced fibrosis, where if you don't act, they will come to have cirrhosis, which we'll talk about more tomorrow. That's the other end of the spectrum, patients whose liver disease doesn't present with signs and symptoms, but comes to your attention by lab, either by accident, or hopefully because you looked at the patient and said, you got hypertension and diabetes, and I wonder if you could also have liver disease. Let's check some blood tests and see if we need to follow up on that. The abnormalities in liver disease, and fatty liver disease, as I say, may not be much, but if there's one test that's most likely to be elevated, it's actually the GGT. This is just the various tests and their height, and the bar reflects how commonly they're found in percentage terms. So, more than 2/3 of patients will have an elevated GGT. Small numbers will have elevated liver tests of other kinds. So it could be very subtle. It could come under the radar and hardly be, dramatic to you at all. When we talk about non-alcoholic fatty liver disease, we're really talking about a spectrum. In fact, in almost all liver disease, there's always an element of spectrum from severe to less severe. When we talk about non-alcoholic fatty liver disease, and you will hear this uneuphonious acronym NAFLD on the wards, you're talking about what includes some patients who really just have fat in the liver and not a lot of injury and not a lot of transaminase elevation, and you'll have a cohort in which the fat has induced a frank hepatitis inflammation in the liver. So you'll have this spectrum, and these are the ones that are at more higher risk of progressive nature. And those are sometimes called non-alcoholic steatohepatitis with the acronym NASH. So the reason I'm putting this up here, it's a little more detailed maybe than what we've been talking about, but you're going to hear people talk about NAFLD, and you're hearing about talking about NASH. And the difference is NASH is a subset of NAFLD. NAFLD includes both steatosis and NASH. So it's sort of the two ends of the spectrum, just so you'll know what that nomenclature means. As I say, it soon will be the most common cause of transplantation as hepatitis C drops down and NASH increases. We can guarantee that's going to be here by the end of the year. On the other hand, when they do liver transplantation, they do just as well as people transplanted for anything else. So it's available to patients who qualify. I mentioned earlier, it's non-alcoholic fatty liver disease. You have to exclude alcohol. You can't tell in the slide whether it's alcohol or non-alcohol. In other words, this is a curious diagnosis that's partly hard and partly soft. And by soft, I mean the patient has to give you an accurate history. Or maybe I should say you have to obtain an accurate history. And that's not always that easy. But I'll just throw in two little things that you might consider. One is there's a very simple 4-question screen that's pretty accurate for getting at least a history of alcohol excess. It might not be related to liver disease. It might be related to liver disease. It's 4 questions. Have you ever thought about cutting down on your drinking? Have you ever been annoyed by people like me asking you if you'd cut down on your drinking? Have you ever felt guilty about the amount you drink? And do you ever wake up in the morning and have something to drink to settle your nerves? It's sort of an anachronistic nomenclature. Used to be called an eye-opener, but that makes the acronym CAGE. And any 2 positives, highly specific and sensitive for an alcohol issue. May or may not be a cause of liver disease, but it's a simple, easy way to screen for alcohol. The other thing that's worth knowing is that a pint a day of whiskey for about 15 years is enough to make a person cirrhotic from their alcohol use with about a 50% chance. And a pint of alcohol, a pint of whiskey is about the equivalent of somewhere between 12 and 16 beers, or 12 and 16 shots, or 12 and 16 glasses of wine. They all have about the same amount of ethanol in them. So if you're just sort of thinking how much is enough to get cirrhosis, people that have been drinking a 12-pack a day absolutely are in the market for that problem. And New Mexico, unfortunately, is pretty high in the country with respect to, this is deaths from alcohol per capita. We're the blue line, needless to say, compared to the U.S. And if you look at our chronic liver disease rates, especially among Hispanics and Native Americans, we are way above, for male and female, national rates as well. So it's a big problem here in New Mexico. Last couple of slides, just to touch on some of the other specific diseases that we have alluded to here. And this is not a lot to wrap your brain around for each one. You could spend a few hours on each one, but for the moment, it's just getting to know you might say. The iron excess condition of hemochromatosis, born with a mutation, and there are a number of different mutations you can have, but born with a mutation that ultimately leads to the accumulation of iron in a number of organs, but the liver is particularly sensitive, and so a patient might come in at age 45 or 50 or 55 with evidence of liver disease, elevated liver test, turns out to be a chronic disease they've had for a long time, and when you look into it, it turns out it's iron overload. You can treat that, but you can't undo the damage already done. Autoimmune hepatitis, we alluded to earlier, often, though not always, presents really acutely, an acute presentation, but it can also be a chronic disease. The autoimmune profile includes some markers. The anti-nuclear antibody is the one we touched on earlier, and that's the most likely one to be elevated. It's not specific, but if it's elevated, it's a young woman. It's usually 9-to-1 female. Acute hepatitis, injury, transaminase elevation, you have to think about autoimmune hepatitis, quite treatable. Alpha-1 antitrypsin deficiency, we see it I see a half dozen cases a year, but in primary care you wouldn't see this very much. It all depends on the referral pattern, But this is another autosomal recessive mutation, and the liver has trouble, the body has trouble with the production of this antitrypsin antibody, which can result, antitrypsin protein, which can result in lung disease from trypsin unopposed digesting the elastic elements in the lung, but it can also cause chronic liver disease. So these are the kinds of things that you're screening for if somebody has liver disease. You're thinking about they have a pattern of transaminase elevation. These are the things that are in your differential. If you have a 36-year-old male who's got these non-specific symptoms, malaise, nausea, anorexia, and dark urine jaundice, sounds like the young lady, right? It's the same sort of non-specific presentation. His alkaline phosphatase, his alanine transferase, his ALT is 320. Hers was in the 800-900 range. His alkaline phosphatase is a little elevated at 120. His bilirubin is 6. So once again, you would agree it's an injury pattern, mostly transaminases. It's a little bit of elevation of the alkaline phosphatase, but mostly it's the transaminases. He took amoxicillin last week. You get that out of the history. You're thinking about drugs. Could this be drug-related? Amoxicillin is not an uncommon cause of liver injury. He traveled in Tunisia last month. There's some epidemic diseases in Tunisia. He had 3 transient sexual partners 3 months ago. Doesn't really know too much about them. There's some risk factors there. He was using injection drugs 6 weeks ago. So here we have a pretty broad set of possibilities. All of them distinctly possible, all of them with the exact same presentation. Right? He could have medication-related disease. He could have hepatitis A, which you would sort out by a simple blood test. He could have, from his sexual acquisition of hepatitis B, it's transmitted by sexual transmission and intravenous drug use, both. Different set of blood tests you do for that. He could have hepatitis C. Hepatitis C doesn't usually present with quite so much jaundice, but it could. So all of those things are possible with the very, very same presentation. And just to touch on those briefly, these different kinds of viral hepatitis, and then we're about done here. Hepatitis A is an RNA virus with fecal oral transmission, so it's often epidemic. It's always acute. That is, there is no chronic phase. If it doesn't kill you, you'll be immune to it. There's a great vaccine, which all of you presumably have had or should have had, which is absolutely protective. It has a very high case fatality ratio in older people or people with underlying liver disease, so we try and get everybody with liver disease vaccinated against hepatitis A. The hepatitis, the alphabetitis with the vowels, hepatitis A and hepatitis E, are both very similar. They're both RNA epidemic, fecal, and therefore potentially waterborne illnesses that are acute and not chronic. Hepatitis B is a much more complicated DNA virus, which can present in the same way acutely, but can also be acquired at birth through placental blood, in which case it's much less likely to cause an acute illness and much more likely to become chronic. It is a powerful, as a chronic illness, it is a cause of probably the largest number of cirrhotic patients in the world are because of hepatitis B, because the disease is endemic in Asia and sub-Saharan Africa, and it is an incredibly powerful carcinogen in the setting of cirrhosis in particular. You think about tobacco as a carcinogen, it probably increases your risk of lung cancer 20-fold. Hepatitis B with cirrhosis increases your risk of liver cancer about 200-fold. So arguably the discovery of hepatitis B, the development of a vaccine by Dr. Bloomberg back in the 70s, has been the single biggest impact on cancer in the world by reducing the risk of hepatitis B. It's a great story. We still see hepatitis B in this country. Nowadays it's mostly in injection drug users or in immigrants from areas that have endemic hepatitis B. And by the way, hepatitis B can incorporate into the genome, into your own DNA, so you may clear hepatitis B of infection and yet have a small amount sequestered, usually in the liver, and if you're ever immune suppressed, you may have it recur. So even though we talk about hepatitis B as in some cases resolved or cured, immune suppression, all bets are off for hepatitis B. Hepatitis C, the most common in our country, in the Western world of these, not the rest of the world, RNA virus. Rarely is it as acutely ill as this guy, but occasionally we've seen a few cases like that. But it's a very common cause of chronic liver disease that we'll talk about tomorrow. And I don't think we have to talk about the serologies in any detail, but just so you know, hepatitis A, there's an antibody that develops by the time you're jaundiced, you probably already have the antibody, the acute antibody, the IgM, and then the IgG will rise later. That means you could be in this little window area between the two and fail to recognize hepatitis A, but the serology is pretty reliable. Hepatitis B serology is much more complicated because it can be chronic or not, and I don't think we really should talk about that today, but just to know that it's much more integral to the care of patients with hepatitis B because it reflects more than the acute illness. And hepatitis C, same thing. You develop an antibody as the virus and the transaminase elevations decline, but the antibody does not mean that you're cured. The antibody hepatitis C means you've been exposed. It doesn't mean that you're now resolved. I think I better skip this, Dr. Hansen, because this is so beginner. But I do. Yeah, so I'm just going to come to one last case, and then we'll be done. A 17-year-old female went into dermatologist for acne. They wanted to use isoretinoin. This is a drug that can have liver toxicity, so they check liver tests beforehand. That's part of the protocol. Her AST was 330, her ALT was 410, and her bilirubin was 2. She felt fine. She had no symptoms at all. She felt perfectly good. What do? INR, you want to know, is she on the front end of something serious like the first patient? We'll talk tomorrow about why a platelet count would be helpful. You'd think about iron. You'd think about autoimmune hepatitis, a young female. You'd think about viral hepatitis. You check those markers, but there's no syndrome. It turns out that she has autoimmune hepatitis, where antibodies attack the hepatocytes themselves, most common in young women, and can be a very devastating disease. Without treatment, the survival is about 10 years. With treatment, it's normal. And in this case, it came to light strictly by blood tests. And patients can present this way already cirrhotic. That is already with disease of such duration that they're no longer it's not really an acute presentation. It's the acute recognition of a chronic disease. So, in summary, we talked a little bit about some of the diseases that present as acute liver tests. Tomorrow we're going to talk about chronic liver disease. We talked briefly about the viral hepatitis family and autoimmune liver disease, iron excess. Alcoholic liver disease and non-alcoholic fatty liver disease we'll talk a little bit more about, and you'll hear more about soon. Wilson's we talked about not because it's common, but because it's such a good reminder of the severity of things. We've skipped primary biliary cirrhosis today. We'll touch on that tomorrow. But these are all illnesses that can present with that viral syndrome, non-specifically, or with nothing at all, just because of liver tests. Then you look at the liver test, and you look at the pattern of injury, and you decide if you need to pursue one set of diseases or another. And this is sort of a summary of what I'm saying more simply, and I think we'll leave it at that. I should tell you at least this, that the severity of the liver disease in laboratory testing is generally proportional to the symptoms. That's sort of intuitive. High bilirubin is more severe disease when they're presenting acutely. But in general, as we said earlier, transaminase elevation in particular really doesn't give you prognosis. Mild disease can be without symptoms at all.